Hello, Kristen Calloway back talking about airway reconstruction post-operative care. So the goals for this talk are to go over post-operative care and management following complex airway reconstructive procedures. We'll discuss how often you want to take your patients back for bronchoscopy to take a look at their progress. We'll look at complications as well as troubleshooting. So for all types of airway reconstruction, that is single stage, this is 1.5 stage, this is double stage LTRs. This also applies for your slide patients or your tracheal resection patients. Everyone, first and foremost, needs an emergency airway plan, which is clearly communicated and documented. This is especially important to communicate this to your pediatric ICU colleagues, as well as within surgery itself to your anesthesia colleagues. Everyone really needs to be on board. Post-operatively, all patients are placed on antibiotics. Preferably, this would be ampicillin and sulbactam, unless they're allergic. The common name for that is Unison. So the reason for that is you want to put them on antibiotics while the drains are in place. And usually the neck drain is in place for about 1 week. That's a foreign body. You want them on antibiotics, and regardless, if they were to have any sort of leak through their anastomosis, you would like them to be well covered. Secondly, our second line of defense is to place patients on anti-reflux medication for 3 months after surgery. So that helps keep inflammation down and keeping our sites happy where they're trying to heal. We find it useful to have stable access for these patients. We prefer PICC lines, so these are peripheral IV lines that are placed in the pediatric ICU post-operatively. If those aren't available, central lines or whatever your institution prefers. All patients should get a post-operative chest X-ray to check for a pneumothorax after a rib graft harvest, if they had a rib graft harvest. We find chest X-rays to be helpful for placement of tubes and checking to make sure everything's in the right spot. And finally, because all of our patients have had an open airway, we also recommend a bowel regimen in order to prevent straining and subsequent crepitus and air leak into the neck. For laryngotracheal reconstruction patients who are in a single stage or 1.5 stage plan, they come to the unit nasotracheally intubated. So the number one issue with this is that you need to make sure that the nasal ala are monitored and the depth of the nasotracheal tube is recorded. So taping of the endotracheal tube can be tricky, but you want to make sure that the nasal ala is exposed so that you can check it, preferably twice a day, in order to make sure that that skin that's so sensitive is not breaking down. Secondly, we find it useful as far as monitoring the nasotracheal tube depth to put like a mark on it so that you can make sure that that mark isn't migrating. If your endotracheal tube has markings as far as how many centimeters it's at, which most do, you can also monitor it that way. These patients need NG tubes if they don't have a G tube already for enteral feeding. We usually place those in the operating room, and they'll need a post-operative KUB in order to check the placement of that, if that's something that your institution does as a standard. And these patients will need sedation for 1 week in the pediatric ICU with subsequent bronchoscopy. So older and calm children may be awoken and mobilized early. This is if they are able to tolerate nasotracheal intubation and walk around and not be irritated by that. For double stage patients, these patients have a stent with the proline stay sutures with an air knot in the neck. I have diagrams later in this talk to talk about taking that out. There's no need for sedation or paralysis in these patients, as the whole goal of the double stage is to not have them on the vent. They do need an MBS to assess for aspiration,
or a swallow study. This is usually done whenever there has been a laryngeal fissure, to make sure that those vocal cords are closing properly and that it's safe for them to swallow. If they're awake enough, you could do this post-operative day 1. You want to make sure it's communicated that the patient is not bagable or intubatable from above. Due to that suprastomal stent, they are not going to be able to have any sort of manipulation above the trach, and the trach is their one airway. So that it is essential to communicate this with the pediatric ICU team or anyone taking care of them. Finally, sometimes these young children have difficulty with managing their secretions, and atropine drops can be useful for while the stent is in place or even afterwards. For cricotracheal resection, and slide tracheoplasty patients, you want to limit their neck extension. So we find that a zero monofilament chin to chest suture is useful. You want to maintain the head in a neutral position with this stitch, and it's uncomfortable if you maintain the head in flexion, actually, and so that's not recommended. On postoperative day 1, if they're extubated, you can always check for cord mobility with these after these procedures, as the recurrent laryngeal nerves are at risk. You want to get an MBS while they're awake in order to make sure that it's safe for them to swallow. And finally, I would note that balloon dilation is actually not considered for their postoperative day 7 bronchoscopy, and you don't want to consider this until 6 weeks following a slide tracheoplasty specifically. So we'll go over plans for postoperative bronchoscopy. Usually for airway reconstruction, you want to take a look at what things look like at about 1 week. There's also an opportunity for 2-week bronchoscopy, and again, this is just to check your graft placement, your anastomosis healing, and to make sure that there's no signs of infection or displacement and that you have a patent airway. For double-stage laryngotracheal reconstruction patients, they do not necessarily need to remain in the hospital for their oral sedation wean between 1-week bronch and their 2-week bronch, because they were never on sedation to begin with, or they shouldn't have been, rather. So here are some examples of some findings at the 1-week postoperative bronchoscopies for LTRs. So on your top left, you have your single stage. This person had a posterior graft. The 1.5 stage also had a posterior graft, and you can see the anterior graft as well. And the double stage also had a posterior and anterior graft, and this is just how they're healing. And it doesn't, the double stage picture has a little bit of bleeding there, most likely irritation from the stent. So stent and tube management, of note, for a single stage patient, you want to wean the vent to extubate following this bronchoscopy. So when you take them back for their postoperative day 7 bronch, you can replace the endotracheal tube, and they can be weaned from the vent and extubated in the pediatric ICU, potentially the next day. So in order to wean the vent, you want to make sure that certain parameters are met. So you only want to extubate them when they are wide awake, so you want to make sure that their sedation is completely off. You want to have heliox available in case you need any adjuncts for their management. And CPAP we have found to be okay if it's administered at a low setting, and we would consider this 6 centimeters of water or lower. As far as 1.5 staging, you'll extubate these patients in the operating room during the post-op day 7 bronch, and you'll change their trach to a cuffed trach. And so then the vent can be weaned post-operatively, and you can take that cuff down when they're ready. For a double stage procedure, the goal will be to remove that suprastomal stent in the operating room during the post-operative day 7 bronch. And this is how this goes. So these are some drawings showing that the air knot for that monofilament suture will be on the right side of the incision. And so the goal here is to cut the air knot through the incision. It will be passing through an angiocath, which is situated in front of the trachea,
And when you cut the air knot, that will release the stent from being held in place. Then you can take the stent out endoscopically through the mouth. So you use a big alligator to pull the stent out through the mouth once the knot is cut in a transcutaneous fashion. And this is an example of a moderate suprastomal granuloma after the stent removal. And we find that treating these with Ciprodex is very helpful. So you can apply the Ciprodex in the operating room and then continue nebulizations after that. And those could be those nebulizations should be through the mouth or administered through a mask at the mouth. These are some examples of expected findings after 2-week bronchoscopy for single stage, 1.5 stage, and double stage. And for laryngotracheal reconstruction, balloon dilation may be used as needed. So that's the end of our talk here, and we'll talk about complications in the next one.